So welcome everybody to the second of our 10-week series on innovations in community care. This is a series of brief talks on important topics in family and community medicine. I'm Christine Morgan. I'm the Residency Education Manager for the Wright Center National Family Medicine Residency Program. Each week, our speakers are faculty members in our program from one of our 4 training sites: El Rio in Tucson, Arizona, HealthPoint in Auburn, Washington, HealthSource in Richmond, Ohio, or Unity in DC area. We are the largest accredited program by ACGME in the country, and we are happy to have full ACGME accreditation along with osteopathic recognition for our program. At the conclusion of tonight's session, you will have the opportunity to speak to our residency faculty that will stay on and answer any of your questions. So with that, I would like to introduce our speaker, one of our faculty members at our HealthPoint site in Auburn, Washington, Dr. Aleinikoff. She's going to speak to us tonight about innovative approaches to refugee healthcare in an FQHC setting.
Great, thanks for that introduction. I'm going to go ahead and share my screen. Hopefully you all can see that. So as per the introduction, my name is Shoshana and I'm a family physician, and I do full spectrum family medicine. So deliver babies and take care of people throughout the life course. And I have been intimately involved in the residency at the HealthPoint location over the last 6 years, and have this year really focused on refugee care, and I'm no longer in a core faculty role, but I'm still quite connected to the residency, particularly in this way. So I'm excited to talk with you today about that. So just so that we're all kind of on the same page and speaking the same language, I always like to start with a really macro view as we talk about refugee care, and just say that there are huge numbers, to the magnitude of 80 million forcibly displaced persons around the world. And I think what I talk about when I talk about refugee health in an FQHC setting, particularly in our FQHC, is such a small proportion of a much larger global problem, right? And when we think about refugees and we think about who we may be seeing in our clinic visits and the families that we have the honor of interacting with, it is the small minority who actually make it to the US and make it to our clinics. And I always show this just to really remind people that the large majority of hosting countries for refugees are neighboring countries, are not the US. It's, you know, a pretty, I would say, yeah, neighboring countries share a lot of that responsibility, and you can kind of get a sense of the details of the numbers, and I wouldn't worry too much about remembering those, but I just wanted to give some global context to this. And I know some of you mentioned in the chat that you're really interested in global health, and I think this work certainly ties in nicely for those interested in global health. So I also like to give a little bit of a political or a historical context for where we are at, kind of zooming into the US perspective. And this graph just shows you over the last 40 years, kind of what refugee resettlement has looked like across the US. And the president sets the number, the annual ceiling, the number of refugees who will be admitted to the US. And then due to processing and other kinds of things, sometimes that number is met or sometimes it's just below that number. And what you can see is kind of in recent years, really 2016, 2017 was kind of peak years for refugee resettlement. And then with the change of the administration, the federal administration, the ceiling number also changed. And therefore the number of refugees admitted to the US went down dramatically. And of course, in the last year and a half, a lot of that was not just governmentally imposed travel restrictions, but COVID-related travel restrictions. I am very proud to be able to add a star to this graph and to this picture to show you what the Biden administration has set out in terms of their plans for refugee admissions. And you can see that if we meet those goals set out by the administration in the next year, we will be back up to historic highs within the last decade. And again, right? We're looking at the magnitude of 100,000 roughly, which is really, really, really small in terms of the global magnitude of displaced persons. I can't give this talk today without at least mentioning and acknowledging, and we could spend more time if people are interested in talking about current events in the last week in Afghanistan. And just to say that the numbers that I'm presenting to you here are those with a refugee status. There are a large number of people who have arrived from Afghanistan over the years and will continue to arrive, hopefully in large numbers in the coming days and weeks, who have a slightly different designation called an SIV designation, Special Immigrant Visa. And those are individuals and families that come through essentially the same process. So for health purposes, we can think of them as one and the same, although that number is not included in the graph presented here. So I think that we will actually be seeing many more newly arrived families. They just don't have that same refugee designation. People often ask me, well, where do people come from? And I've been working in Washington for a number of years now, so this kind of gives you a sense of, at least within Washington, which tends to parallel the rest of the country. I'm very proud of our state, and despite being small in population, Washington in the last really 6 or 7 years has pretty consistently been in the top 4 receiving states for welcoming newly arrived refugee families. And certainly the large majority of those who are resettled in Washington end up in King County, which is where our clinic is located. And about 2/3 to 3/4 of those resettled in King County, where we practice, actually establish with HealthPoint as their medical home. So this is definitely some patient population that we really think of as the community that we're part of serving. And you can kind of see over the years how things have changed in terms of where people are coming from. And I think we'll continue to see shifts depending on what's happening globally, because global politics always impact displacement and therefore arrivals. So the point of this slide is not at all to have you memorize or understand the process by which a refugee comes to the US. It is really just to show you that there are so many steps in this process. And by the time that a family has arrived and is seeing you in the clinic, they have been through a host of interviews and security checks and medical checks. And sometimes this process takes many years, not just months, and people are in waiting for a long time to be able to undergo various parts of this process. And if travel is delayed at any time, like a global pandemic, which delayed travel for a lot of people, much of this process expires and starts over. So I think I always just have that perspective when I'm seeing someone about how much they have been through just to be given the opportunity to come to the US and to be also seen in our clinic under this refugee status. So from a little bit of a health perspective, and I'm going to talk a little bit about what happens locally in our region, and I will say that in talking to people across the country and being in national meetings and conferences, this process does look a little different depending on the area of resettlement, but it tends to follow a pretty similar pattern, which is that from a medical perspective, refugees are screened overseas before they leave the country. And they have a very basic medical screening that's pretty prescriptive, that's run by the IOM, and there's a lot of information about exactly what happens in that examination. And then if they're deemed fit to travel, meaning there's no active infectious disease that would put them at risk for being on an airplane, or any other reason that they're not able to travel, then they do travel to the US. And when they arrive in the US, they are paired with a resettlement organization, of which in our region there are 5. Nationally, there's a total of 9 that operate in various locations. And that resettlement organization has a caseworker that's assigned to the family. There's often language and country of origin congruence between those caseworkers and those individuals or families. And that caseworker is really in charge of helping them attain what the goal is, self-sufficiency in 90 days, which is kind of insane when you think about what that actually means, right? You're showing up to a new place where potentially you don't speak the language, and you're expected to get a job, get your kids enrolled in school, have all of your health squared away, and be able to pay your rent and pay for your basic necessities in 90 days. But that's the task at hand. And from a health perspective, that resettlement organization helps families get established with a refugee screening clinic. Some states and some regions, the refugee screening clinic is actually embedded in a community health center. In Washington, it's a freestanding clinic run by public health, where additional labs, vaccines, examination is done, and then they get referred to primary care, and potentially referred to mental health care, or sometimes we make that referral or partnership. And like I mentioned before, HealthPoint has been by and large, the single largest provider of primary care for these families in our region. So what that has meant is we have had lots of families coming over the years, hundreds of families establishing care at our clinic. And that has allowed us to see really high volumes and think creatively about ways to better meet needs of the families that we're seeing. And so I'm going to talk about a couple of those today. That's how I'm going to end. And I'm happy to answer questions about any of these models or how they came to be. But one of the things that we were noticing is we would have families, maybe a family of 8, for example, and they would be trying to establish care at our clinic, and we would be coordinating with the resettlement caseworker, and we would have the mom scheduled on one day, grandma scheduled on another, dad scheduled on another, 2 sibs on one day, 2 sibs on another day with a different provider. And we were asking this family who was brand new, without transportation, without literacy or health literacy, to come back to the clinic 8 different times to see a whole different number of providers and potentially retell their story over and over again, which can be not just exhausting, but also traumatic. And so we said, wait a second, this is not very family-centered, right? What can we do to change our system to better address family-centered care in the way that we would hope it would be delivered? And so we decided to start doing something called what we call refugee clinics, which is essentially we block a provider schedule. This started out just being me, but now we have a whole host of providers, both at our site and at other sites, that are doing this work. And the entire session, so that entire half day, they're just seeing newly arrived refugee families in entire family units, right? So instead of, that family of 5 being spread out across the month on different providers, they are coming in and they're seeing one provider, all 5 of them. And the beauty of family medicine is that it doesn't matter if someone is pregnant and someone is a kid and someone is an adult, right? We can care for that entire family. And I can't tell you how many times I've just sat down and said to families, welcome. We are so glad that you are here. We're so glad to be a part of your care and your care team. And I'm going to be your family doctor, which means that I can take care of all of you, and you can come see me when you're not feeling well. And I also want to see you when you are feeling well. And we kind of talk about preventative medicine and what we do in family medicine. So, and people just kind of light up, like, I've been through all these different screening processes. I've met all these care providers along the way, and you're telling me like, you're going to be my family's doctor. And people literally look at me and say, you're going to be my family's doctor? Like, for real? Yeah, that's what we do, right? That's what primary care is all about. It's just really beautiful. But we work in a team. It's not just the primary care provider that families need to see. So what we have set up in these refugee sessions is we block a provider schedule. We also have a nutritionist that works with us and a behavioral health consultant who works with us. So really it's all about team-based care and really trying to understand, both from the medical literature and also from getting to know patients, what families' needs are like, and then being able to incorporate in as many ways as we can of trying to meet those needs in the first visit. So what that often looks like is a lot of help and support to get families to that visit, be that transportation, ensuring that we have proper interpretation, ensuring that we have records from overseas and from any recent screening that was done so that we don't duplicate work, having a lot of prep time with the team to ensure that we are really prepared when we see them to really make the most of the time that we have with families. These can sometimes be long visits, so we want to make sure that we are mindful of that for families. And then, like I said, doing team handoffs to show kind of who the team is, who wants to care for this family. We often have our nutritionist come in, and if there's no nutritional questions, kind of gives the welcome to the US. Here is some tips around healthy eating. Some families may have never had food choice if they were living in a refugee camp for the majority of their life and relying on, food allocation programs. Others may not have had the opportunity to eat fast food before. And so we try to do some coaching around that. And then we have our behavioral health team come in and just really normalize. Some people are experiencing, a lot of sadness being away from their home or their family. Others have anxiety. Some people have trouble sleeping. Some people have no problems at all. And we just say, you might be doing great now. And if that changes at all in the future, we're here for you. We're your medical home. And this is part of your medical team. We care about your well-being and your mental health. We also have a dental clinic. And so we encourage families to get scheduled with dental, and at times have had our dental hygienist actually come into the room and meet with families. We know that dental care is a huge unmet need for many refugee families. And then we have a host of other people who kind of connect them to other services as needed, and we give them a tour, get them to the pharmacy. Many of these individuals need empiric treatment for parasitic infections on the first day, so we do a lot of counseling around that at our pharmacy. And then we ensure that we have all of the follow-up plans arranged and ready to go. So that's kind of what a typical refugee clinic looks like. They're super fun to do. We have found that providers really enjoy these sessions, and our whole staff. Some of these pictures, as you can tell, they're mask-free, so they were taken pre-COVID, but we have continued during COVID to do these actually over telehealth, and we have just started in the last month welcoming these families back in person per their preference. There are some families who are recently arrived and really prefer to do telehealth visits until they're fully vaccinated, and we are respecting that, of course. As we are seeing, so I'm going to switch gears a little bit and talk about another kind of program that we have for refugees. As we were seeing many families, we were starting to notice some patterns. And I would say, as an OB provider, I was seeing a lot of OB patients, and I was noticing that many of them were from Afghanistan, and many of them, I would go down the hallway and I would see my 9 o'clock patient, and I would see my 9:15 patient and my 9:30 patient, and they were all women from Afghanistan who were pregnant and kind of experiencing pregnancy alone. And many of them expressed to me, in Afghanistan, I lived with my sister and I lived with my cousin, and we were all pregnant together, and we would go through this together. And a lot of times it can be very isolating. We're in a completely new place. Particularly, many of them had husbands or partners who were in the workforce, and so outside of the home, which was further kind of isolating. And we kind of started thinking like, well, what would this look like if instead of each of you going through your pregnancy alone, we found a way to bring people together? And with that, we started talking to particularly our Afghan newly arrived refugee families, and kind of asking if what model might be a good fit and what the interest would be, and would this happen in a clinic setting? Would this happen in the community, at the apartment complexes many people are getting resettled in? And far and away, we heard like group prenatal care was a big interest. And instead of reinventing the wheel, we looked towards evidence-based group prenatal care models and landed on Centering Pregnancy, which is a group prenatal care model. And we kind of just started a pilot to see like who's going to really show up and how is this going to go. And every single woman that we invited showed up and continued to join the group and wanted the group to continue even after they had delivered their babies. And so that was, I think, about 4 years ago now. And I think we are on our 13th group. So basically, we've seen 13 cohorts of women from kind of the beginning of their pregnancy through their pregnancy, as well as in their postpartum course. And that program has grown to be just the standard of care. So I've facilitated a handful of groups in Dari with the help of a Dari interpreter. We also have Spanish groups, English groups, and we've had some multi-interpreter, multi-lingual groups, which is always really fun. In fact, I facilitated a group of 6 pregnant women. None of them were born in the US or from the US. And they were all due right at the same time. And we found a lot of commonality across a lot of commonality kind of across different cultures and the way that birth is perceived. And so that was a really fun group to be a part of. And so that's kind of another, just, as you're seeing things and you get excited about your patients and you're really looking to listen to them and to listen to their needs, then you can kind of create innovative programs that also make your job more fun. And the final thing I wanted to mention is I've had over the years a lot of interest from really excited learners, which has been just amazing to see. And certainly the residents keep me really energized doing this work. And so we've put together an elective, a refugee elective in Washington to really allow residents who want an in-depth kind of experience over the course of a month, not just on the clinical aspects of refugee care, but really understanding who are the community-based organizations that are partners in this work, really doing the heavy lifting, and who can we lean on, and who are the people providing intensive case management to families who are struggling, and just help residents who may not have personal or professional experiences with newly arrived families in the past really get that experience to be the best family physicians possible for these families. And a lot of our residents who have gone through this elective have come out choosing jobs after residency where they intentionally are working with newly arrived families. And I would also say, I think since at HealthPoint, we see a lot of newly arrived families in all of our clinics. I've had a lot of feedback from residents who have gone through the elective, and they'll send me a message in the chat or text me and say, we talked about TB, and then I saw a patient and I knew exactly what to do. Or I talked to a patient and I asked them who their caseworker was, and they were so happy to talk to me and to understand that I knew that they had a caseworker and what that process was like. And so I think it's been really a great learning opportunity. And I certainly would encourage you, if this is an area of interest, to really try to explore this in your training, if that's in medical school or in residency. There are certainly a large network of providers across the country that are really passionate about this work, and a lot of standardized guidelines that people can help you all to access. So I think with that, I will open things up for questions.
So I know you mentioned about, oh, hi, by the way. I know you mentioned that, like, as a, family medicine doctor that specializes kind of in like OB-GYN, you're able to provide care. But what about for physicians who are extremely specialized, like general surgeons? Do you coordinate with them at all to provide care for these refugees?
Yeah, that's a great question. We definitely really try to do our best to do care coordination. I would say that as a primary care physician, I recognize that care coordination, although I end up doing a lot, is not my area of expertise, and I really want the best for these families. And so I tend to really work on building relationships with community-based organizations and really understanding who the people are in the community who have language and cultural congruency and are doing that work. And I would say over the years, I've been able to really build relationships with people I totally trust to be able to help our families navigate that system, right? Being in a new place, particularly if you grew up in a refugee camp or a place with really limited access to healthcare, it can be really confusing to come to a doctor and then be told you're being referred somewhere else, and it's a totally different building. And how do you get there? And will there be an interpreter there? And will you, so I think there's a lot of questions. And for those patients where we are having a lot of interactions with specialists, we will often try to get a language and cultural congruent caseworker to be able, or case manager to be able to really work with them through that process. And there are certainly specialists that we work with all the time. And I think we're always building those relationships and really trying to help our specialists understand what it means to be a newly arrived refugee family. In fact, I was on a call this morning with some of my colleagues at Ethnomed, which you may be familiar with, is a really amazing resource to learn more about this kind of work. And we were talking about building a toolkit that was more expansive. Previously, the toolkits that we've had on there have been really focused on primary care, but recognizing that in order to care for families, we also really need to have our surgeons on board. And so making a toolkit that's a little bit more expansive beyond primary care is something that's being worked on right now.
Thank you so much.
Somebody asked in the chat, what are the most common conditions, chronic or acute, that come across in the refugee clinic? I think that's a really great question. So I think when we think about global health or we think about refugee care, some of the things that come to mind immediately are these tropical diseases, right? Are people showing up in your office with malaria? Do people have chronic Hep B that's never been treated before? People have active TB, right? And those are all the things that we screen for. And those are the things that CDC really asks us to focus on. But I try, and particularly in that first visit, to put my agenda down a little bit. Like, I know I need to get to all that screening, but what I'm most interested in is, what is the patient's primary concern today? And that could be a whole host of things, right? Maybe that's chronic back pain, like anyone else, right? Or maybe that's, a toothache or something like that. So I think that it really runs the gamut. And I think there are some conditions that we know we see in higher rates, specifically in refugee families. And so it's really great to make sure that we're prepared to manage those things, latent TB, Hep B, et cetera. And then I think the other thing that I often think of is, for many families who have never had access to primary care or to preventative medicine, we're making a lot of chronic care diagnoses, right? People who have never had their blood pressure checked before, people who have never been tested for diabetes, people who have never had a mammogram. So I'm also finding that although we kind of jump to or think about these exotic or tropical diseases, and we certainly I see more parasitic infections in my refugee families than I maybe would in a practice that didn't have immigrant and refugee families present. But I also see a lot of the common things that you see in primary care: diabetes, hypertension, pregnancy, well-child checks, So I think it's pretty representative of what you would imagine in a general patient population. It's a great question.
Any other questions for Dr. Shoshana? Did you say how long the elective is that you developed?
It's a 1-month elective, and within the residency, there are a number of COPC blocks that every resident does, and all of the Washington residents during their COPC blocks have some opportunities to engage with refugee communities through some kind of pre-scheduled opportunities. And then, so everyone gets a little bit of a baseline experience. And yeah, thanks, Esther. COPC is community-oriented primary care. And then for residents who are really passionate about this work or want to dig a little deeper or are thinking about doing one of their projects around refugee care, then sometimes they'll choose to do that elective, which is just a little bit more kind of in-depth exposure to that. And every year we have, yeah, definitely a handful of residents who decide to do that as an elective. I think this year of either 3 or 4. One is currently on the rotation with me now. So, and in that, I should also mention in that elective, they do spend time not just with community partners, but also in my refugee clinic. So getting to do that as well.
Thank you. Any other questions? Hearing none, I'd like to thank everybody for joining us, and I'm going to open it up to just any general questions you have about our residency program. And I will share the screen with the information on our program again. Does anybody have any questions they want to ask? We have faculty from our Washington, D.C. site, as well as from HealthPoint. I see one of our graduates waving to us. So we have faculty and residents that have gone through the program, as well as core faculty on the call with us today. Okay. Well, thank you again, everyone, for attending. This is the second in our series. We'll have another session next Wednesday, so you feel free to join us. And I appreciate your time and attention. And the information is on the Wright Center website about our program, and the recording for the first session is on the Wright Center YouTube channel. And this one will be put up on the channel shortly. So thank you again, everyone.
Thank you so much, Shoshana.
No problem. I don't know if it's what you had in mind, but there we go.
Absolutely. Absolutely. Even though I know the information you're sharing, I love hearing it again.
Great.
Yes, it was very informative.
Good. All right. Well, unless you need anything else from me, I think that's all.
All right. Sounds good. Have a good night. Thanks again.
You too. Bye.
Yeah, thank you, everyone.